My name is Florence. I am a practice nurse and I work at the Lawson practice. I have been a practice nurse since 2003. Prior to that, I worked as part of a district nursing team for 2 years, between 2000 and 2002. And post-qualification, I worked in acute setting at Guy's Hospital on an orthopedic ward. I worked there for 2 years before I came out into the community.
Okay. My name is Carla Ellis and I'm a Band 6 community nurse and I'm based at John Scott Health Centre. Background is a community nurse. I qualified in 2015 as a nurse and I came straight into community and that's where I've been ever since. Before coming into nursing, I worked as an information coordinator at the Whittington. I did substitute teaching before, so I trained as a teacher.
At my current post, I work 3 days a week. Last week, I saw about 50 to 60 patients, ranging from young children to elderly patients and middle-aged people. The young children, mainly it's coming in for childhood immunization. For the young adult and middle age, it would be for things like contraception, men's health, women's health, smear test. It could be travel health too. And for the older people, mainly it's for long-term condition management. So it could range from people that have come in for management of their diabetes, COPD, hyperthyroidism, and so on and so forth, to wound care. Of the 50, maybe about 25 to 30 of them would be older patients coming in for mainly management of their condition, because majority of them have long-term conditions. For diabetes patients, I would look at the HbA1 level, because that is the gold standard in terms of how well they're managing their diabetes, and look at what physical activities they're doing, how they're managing their medicine and all of that. If there's any issues with the patient, we discuss in that consultation and try and help. If blood test is due, it will be done in that consultation, because we try and minimize. Bear in mind that most of them are frail, older patients. We try and minimize them having to call them back and forth into the surgery. So we'll try and do as much as possible. So if they need blood taken in that visit, it will be done either by myself or a healthcare assistant working to support me. We do foot checks and weight management, and dietary and lifestyle modification advice is also given during the session. For COPD patients, it will be mainly monitoring their lung function test, nutrition, because sometimes some of them would have issues with weight loss due to their condition. So we look at that and try and support them. And also in terms of inhaled respiratory medicines, we also try and look at if they're on the correct device for their condition. If not, so I work with the GPs and pharmacies. I can seek advice from them if I think the medication that the patient is on not appropriate or not controlling their symptoms appropriately at present time. Yes, during the half an hour review that our patients come in for, about 10 minutes is used for measuring, where we'll measure the vital signs and do blood pressure, height, weight, check oxygen level, and then the rest is basically asking the patient how they are. So for example, if it's someone with COPD, they've said to me, "Oh Florence, my breathlessness is worse than the last time I saw you," then it's looking at what can we do. We can't get rid of the breathlessness, but we can do things to make it better. So it'd be me discussing with them, range of activities they can do at home, or if I could refer them to a specialist to go and have special exercise like pulmonary rehab to help them learn how to use strengthen their muscles and breathe better. It could be something as simple as that.
Last week on average I saw about 50 patients, and these patients included mainly the elderly, and the types of care that and assessment that I carried out was medicine management, which includes administration of insulin, and leg ulcer management and assessment, so that's wound management, and palliative care, so that would include end-of-life care, including providing syringe driver for the patient, incontinence assessment. So those were the kind of tasks. I think the majority of the patients that we saw had chronic illnesses, so the leg ulcers, the diabetic patients, the long-term conditions, chronic condition. Episodic, I would say, would be the least amount patients that we saw. So if I use leg ulcer management as an example, I would say we could see them on average twice a week. Yeah. So
twice a week for how long?
Twice a week. It's based on assessment. So you could see them 3 times a week, twice a week, and sometimes this can go on for several months. So you can see someone twice a week for, say, 6 months. I think we see the vast majority of patients in their homes. Probably about, say, 90% are seen in their own homes.
Majority of our cases are dealt with in the surgery, but on special, exceptional cases, we do visit patients at home. So say, for example, I haven't been, but I know some of my colleagues have been, to visit a patient at home and do a COPD review because the patient is housebound and the district nurses working with us couldn't do those procedures. So one of my colleagues has gone out to the patient's home to do the test. And in the past, not at this current practice, I've known people to go home and do smear tests on a one-off, but it's not something we do regularly.
Some of the patients that we see are able to go to the practice. Not many of them. Some are able to go to, again, like for wound care, we have leg ulcer clinic. So if we received a referral to see a patient that we feel could attend one of these clinics, then we would refer them to the clinic. And for the ones who are able to be seen by the practice nurse, then we would contact the GP and ask for this patient to be seen by the practice nurse, but there are not many.
The difference between practice nursing and community nursing, in particular district nursing, would be that there are certain patients that I will deal with that they wouldn't deal with. And then we also have in common certain patients that we both see. So say, for example, someone with wound care could be seen by myself and the district nurses. And on the other hand, someone that's coming for smear test would only be seen by, a practice, or someone needing travel health vaccine would be seen by a practice nurse. So most of the wounds that I would see would be post-op wounds, post-operative care wound, whereby someone's just had surgery or injured themselves. But majority of the wound care that district nurses would do would be chronic leg ulcers or chronic wound, maybe a pressure sore and things like that.
I do see an example of wound care that highlights the difference between practice nurse and the community nurse. We would do compression bandaging and Dopplers, and that's a skill that the practice nurse doesn't have. So, well, some practice nurse don't have that skill. So, for example, a patient might be able to attend the practice, but because the practice nurse is unable to do a compression bandage, then the nurse would either go to the practice to see that patient at the GP practice or see the patient at home. The nurse and the community nurse, we share a similar group of patients. So, for example, we would both manage patients with diabetic. We would both manage diabetic patients. However, the practice nurse would carry out assessments such as COPD assessment, whereas the community nurse would not be doing that.
Diabetic patients, because say for example, patients that are housebound and due to their condition cannot inject their insulin, it will be mainly the district nurses going in to their home to administer the insulin for them. And they saw that, oh, someone needed ear syringing, they might come in and say, Florence, or we've seen a patient that needs ear syringing. If the patient is not housebound, I will get them an appointment and do it. But for patients that are in the nursing home, I will then need to refer to the district nursing team that looks after our patients so that they can have their ears arranged at home. I have appointment books and they're pre-booked appointments, so sometimes waiting could be a week or 2 weeks before, so they're pre-booked in advance. And we also have slots for people that may walk in on the day. So for example, people that need post-op wound care dealing with, or someone that's just accidentally hurt themselves at home and need to be seen by the nurse, or someone that's been seen by the doctor and they felt like, oh, they need nursing input, they'll be put into some of those extra slots that are not booked, that are for the day. Each day we have sessions, so on, for example, on a typical day for myself, I will have 3 sessions. So I have an hour in the morning where I support the healthcare assistants, you know, making sure that the people that come in to have their blood tests taken, everything is all right. Then after that first hour, I then start a chronic disease management session, which runs from 9 o'clock to 12:30, and then we then have a break for lunch, and then have an evening session that runs from 2 till I finish.
What our list is for a day, say if it's Wednesday, we could know by Monday in advance. And the list is changeable. It depends on referrals. We receive referrals from different sources, from the hospitals, from the GPs, from even practice nurses to see a patient, and we can get a referral today to see a patient tomorrow. So even
we have regular monthly multidisciplinary meeting, which will include community matrons, district nurses, health visitors, palliative care, and we all come together and they will all bring issues concerning patients that are registered at the Lawson to that meeting. It's like, so say for example, if you look at it from the palliative care perspective, it could be a patient that the palliative team are looking after, you know, a patient that's registered with us, and they've come in to give updates as in what the condition of the patient is, if they're okay, if the condition is deteriorating, and also those kind of things will be discussed in that meeting. For example, the health visitors, it could be a safeguarding issue with a family or a child.
We have a monthly MDT meeting where we would meet with GPs, it would be with social services would be there, You could have the practice manager who would be in attendance as well. The purpose of this meeting is to discuss the progress of the patient care, any concern that we might have with a particular patient. So say for example, if we would need to refer a patient on to social services because they might need help with a package of care, sometimes we will discuss that. Or if there's a need concerning safeguarding, that we feel that we need to raise a safeguarding issue, that can also be discussed at these meetings.
EMIS, we use EMIS software in the practice, and so majority of the information that I would need to look after my patient would be on EMIS, on the computer, and then I will rely on the patient to, during history taking, to get more information from them as to why they've come in on that day. But looking at past history or ongoing problem, it will be on the computer.
Okay, so we are provided with laptops that we take with us when we're going out on visits, and we use a system called Rio. So that's the system that we use, and everything that we need is on Rio. So our diary is there, the referrals is there, patient contact is there. Sometimes we need to access certain records that is held by the GP. However, the GP practice uses a different system from the one which we use. So we'd have to call, or sometimes that information is contained within the referral. So that's one way that we could access it. But if it's, say for example, we needed the patient's past medical history, which wasn't included in a referral, then we'd need to ring the practice and ask, or send an email and ask that they send it, upload it to us so we could put it on Rio. We can send a letter to the GP if it's something non-urgent and it's just for their information. We can send a letter through Rio. We have a system called DropZone, and we can use Rio to send a letter directly to the GP. Nurses going out to see diabetic patients, perhaps if we could do more of the annual assessments that the practice nurse do as well, if that's something that if we as nurses learned how to do that. I mean, it's not so much that we don't know how to do it, but there's further training required.
From my personal perspective, what's stopping me doing home visits more would be indemnity cover, because I'm not covered to mainly practice my skills in someone's home as a practice nurse, whereas that's not the same for a district nurse. So I'm in a role that I'm covered mainly to look after patients in the practice. So if something can be worked out to change that, there's no reason why I can't practice some of my skills in a patient's home. We do it, like I've said earlier on exceptional cases whereby, if a patient can't come out and the district nurses don't provide such services, like go to a patient's home to do a spirometry review, I would go and do that. And
the relationship between the practice nurse and the community nurse, I would say, is a very good relationship. Where I was based previously, before moving to John Scott, because I'm quite new here, I work very closely with the practice nurses. I usually go into the practice nurse to the surgery about 2 or 3 times a week, and on any occasion I could approach a practice nurse to ask advice about a patient. Say for example, I'm going in to see the patient for insulin, to administer insulin, but this patient is also a COPD patient, and I had some concerns. I could actually approach the practice nurse to ask their advice, because they've got the expertise in, long-term conditions, whereas I haven't. And they in turn could also approach me to ask me about a patient that they would need some advice with. So I think we work pretty closely together.